So good morning everyone. As a topic given to me is scope of newer choice of antibiotics. Now this topic itself requires a lot of introspection because there is very less scope and there are very few new antibiotics coming up in the next few decades. In fact, WHO has approved or CDC approved only 7 to 8 antimicrobial agent for the next decade or so. So now this is what the Sir Alexander Fleming said during his when he got the Nobel Prize in 1945. So during his acceptance of the prize, he made a statement. At that time, he said that it is not difficult to make microbe resistant to penicillin in lab by exposing them to concentration not sufficient to kill them. There is a danger that ignorant man may easily underdose himself and by exposing his microbe to non-lethal quantities of drug make them resistant. So this is what he has said around 40-50 years back. And at that time, the concept of MDR resistance was not there. He was talking only about the penicillin. But now this is what he said at that time, and here we are now. So now we are in a stage that bacteria which show resistant to least, now we are talking about MDR all the way. So bacteria which show resistant to at least 3 different classes of antimicrobial are referred to as MDR and have become common, and there is a risk of entering a post-antibiotic era in which infection can easily turn lethal. So this is what we are now. So we have to very be judicious. Now this is just to show a glimpse of our data. So this is a month of May. So I'm not saying this ICU thing, it's a ward thing. So what we do, every day we collect the data every day and we record how many reserve antibiotics are being used and how many antibiotics are used more than 6 days and how many reserve antibiotics are used more than 10 days. And mind you, these patients are relatively stable. These are relatively stable, they are not ICU or SDU patient. So see the level of reserve antibiotic which are being used in wards also. This is phase 2 data. So every day you can see around 20 to 30% who are staying in the ward, they are getting reserve antibiotics. So without any proper indication, it is all empirical use. And quite a few of them, they use these antibiotics for more than 6 days, and sometime it can go beyond 10 days as well. So this is what the state of affair is. Now, keeping this thing in mind, WHO has laid an action plan. So this is a 3-pointed approach WHO has given. So the first approach was to increase the awareness about the understanding about the antimicrobial resistance. Second was to strengthen the knowledge about and to collect the data. And third is to reduce the infection by including the hand hygiene compliance. Fourth is to optimize use of antimicrobial in human and animals. And lastly to increase the investment in new drugs. It's a very, now it's in this situation now no more pharma company are interested in investing in antibiotics because they also know that within after discovery or after invention, within couple of years, they are going to become resistant. So in fact, FDA is now subsidizing or funding all these pharma company to continue their research on antibiotics. So still we are struggling now. So even G20 countries have taken a stand now. So now since 2017, 8 new antibiotics have been approved by FDA. So this includes one of the drug for TB and one drug for Neisseria gonorrhoeae and 5 for gram-negative pathogen and 1 for C. diff. So I'll be discussing more of them. So WHO has a special focus on dangerous pathogen, and dangerous pathogen we all know. The dangerous pathogen belong to the group of Enterobacteriaceae family. So they are classified as dangerous pathogen by WHO. Now I'll discuss basically about the infections which are for gram-negative bacteria, most of them carbapenem resistance Enterobacteriaceae, and one antibiotic will be, one thing will be against the C. difficile. Now for C. difficile, there is new antimicrobial agent coming up called as Ridiloxazone. This is a new agent, and we all know that C. diff is a worldwide, globally it is a #1 hospital-associated infection, although not so common in India, or maybe it is there but is not being appreciated to that extent. So, and other problem with CDI that is a recurrence. So recurrence rate is very high. In 35 to 65% who has one episode of C. diff, they are supposed to have another episode very soon. And even with the appropriate use of antibiotics, antimicrobial like metronidazole and vancomycin, still 25% can suffer the recurrence. So the guidelines various guidelines which are there, quite a few guidelines are there to manage the primary infection, but there are very few guidelines which are directed toward how to treat the reoccurrence of the secondary infection. So currently vancomycin is being preferred treatment for both primary as well as a recurrent infection. Now fidaxomicin is a new drug which is being there. It has been very hyped, and now it is on the lower, it is not being used that frequently because one is that risk involved, the cost is very high, and secondly, along with vancomycin, it is known to inhibit the gut flora, especially bifidobacterium. It goes down, so that further can lead to increase the chances of worsening of colitis and all. So now currently there are 6 new antimicrobial agents in phase 3 trials, out of which there is one ridinilazone, which is important, so which is being advocated, and it has a huge potential in coming future. So it is given orally and it is poorly absorbed by gut lumen, and it has a selective activity against C. diff. This is very important. It is not killing the harmful good bacteria, but affecting only C. diff. It inhibits the cell wall synthesis of C. diff, and more importantly, MIC values, that is minimum inhibitory concentration values, are lower than metronidazole as well as vancomycin. Now we know that in C. diff it is a toxin A and toxin B, which are the most important virulence factor responsible for most of the symptomatology. So now this toxin, this agent selectively inhibit toxin B, which is more potent and more effective than toxin A. Now one more pathogenesis in C. diff is that there is an increased inflammation because of release of interleukin 8 from the enterocyte of the gut, and this agent is also supposed to suppress the release of IL-8. So in IL-8 in that way it also reduces the gut inflammation. So this is a very promising agent, and in times to come this will be number 1 agent, surpassing vancomycin and metronidazole. So this is the one thing which is coming up now. Now coming to the other gram-negative one, so the tetracycline derivative. So there is one new derivative which is FDA approved, that is called as eravacycline. It's a new agent. It's a fully synthetic agent, belong to tetracycline class. It is approved by FDA for complicated intra-abdominal infection mainly. So that is third. So we know that we have generation tetracycline, then we have now third generation, we have TG-cycline. Now this everacycline is said to be a fourth generation. So basically they are more crucial because basically they escape the mechanism of resistance. So we know that for resistant tetracycline, the true primary mechanism is the efflux pump. So bacteria express various genes which will enhance the production of efflux pump, so that all the antibiotic which is inside the organism, it is flushed out. And second is so bacteria in presence of these antibiotics start producing something called ribosomal protection proteins. So this ribosomal protection protein will prevent the binding of the antimicrobial agent to the microbe. So advantage of these two antibiotics, especially eravacycline, that basically it escapes both these mechanisms. Therefore, drug resistance is very unlikely to happen. And it developed quite late. And more importantly, there is no cross resistance with other class of antimicrobial agent. And MIC90. So MIC90 means minimum lethal dose. As you must be knowing that MIC90 will decide that, at what dose antibiotic will be effective. Higher the MIC dose, the chances of getting resistance is much more faster to happen, and toxicity will be more. A drug having less MIC90 means it will be effective in lower dose, so chances of toxicity and resistance is quite less. So now this drug has a very less, as a MIC90 of very less, and it is even lesser than some high-end antibiotics, antibiotic which are basically used for intra-abdominal infection like imipenem, vancomycin, and even lower than TG-cycline. Now this antibiotic is also active against all the relevant pathogen. It is also against MSSA, MRSA, even vancomycin resistant enterococci, even gram-negative pathogen like E. coli, pseudomonas. It is a broad spectrum of activity. And complication which are associated with tetracycline, they are relatively very less with case of this evaramycin. So there is one new drug. The second new drug is a fourth generation fluoroquinolone called as delafloxacin. This is also now FDA approved. So it is initially approved for acute bacterial skin and skin structure infection. So we know that fluoroquinolone basically act by inhibiting enzyme DNA gyrase, and now this agent along with DNA gyrase, it also inhibits the enzyme. It also inhibits topoisomerase 4. So basically because of two binding site, it binds very tightly. So chances of resistance is quite low, and also transmission of drug resistance, cross resistance is also very less. So it is effective both for gram positive as well as gram negative bacteria. So one more thing about all these skin and soft tissue infection, we know that they are mainly caused by gram positive bacteria, especially MSSA and MRSA. So now what happens is that the skin flora, basically the conditions which are maintained over there are predominantly acidic, because skin produce some substance which create the acidic environment, and even these bacteria find it difficult to survive in this acidic condition. So in order to cause the disease, so these bacteria produce a biofilm kind of thing, so which prevent their killing by the enzyme which are secreted by the normal commensal flora. So now these antibiotics, most of the antibiotics which are being used, so they are basically effective in acidic pH. In fact, all the fluoroquinolones are not affected in acidic pH. This is the only fluoroquinolone which is effective or more effective in acidic pH. So this is why, that is why it is very, it's a novel antibiotic which will be done in future. So very lot of study, and along with that, it also has other advantages like good bioavailability. It doesn't interfere with cytochrome 450. It doesn't other fluoroquinolone. It has no cardiac or phototoxicity, which is commonly seen with other fluoroquinolones. Now another new dimension is being added in this case now. As I have told you that it is the lowest MSC value toward MSSA, MRSA compared to other antibiotics. So shows MSC value equal to 1/5 for ciprofloxacin for treating UTI caused by E. coli. So effective combination of caspofungin against many gram-positive infections. So now that we know that caspofungin is a drug used for fungus, and it basically targets the cell wall of the fungus beta D 1,4 beta D glycan. So what it does, basically the biofilm which is formed by the Staph aureus, the biofilm composition is almost similar to that of the composition of the cell wall of fungi. So when we combine caspofungin with this antibiotic, the effectiveness further is enhanced. So, and it basically inhibits the biofilm formation, which is the main reason why Staph aureus resist killing by most of the fluoroquinolones. So as you can see, various studies have been published in Nature and all, showing that so a major role in Staph aureus, but combination of this is a good option in future. So as I know that bactericidal activity is there, it is more effective for E. coli, UTI, bactericidal effect in 6 hours, Staph aureus in 10 hours. So it is also more effective than other antibiotic against gram-negatives like H. influenza, community-acquired pathogen like H. influenza, Legionella, Pseudomonas, even H. Helicobacter pylori. So its pharmacological data is quite favorable. So bioavailability is quite high even after oral administration. So this does not inhibit enzyme cytochrome P450. So there is no cross resistance with other phenoclones, and it is available in both a tablet and IV form. And basically it is now being tried for the respiratory infection, and in future maybe this is one of the drug which can be used for community acquired pneumonia, which we all know is commonly caused by either pneumococci or Staph aureus. So now for the next antibiotic, I would like to pay some attention on this table. So we know that various enzymes, carbapenemase or beta-lactamase, which are produced by various gram-negative pathogen. So broadly we categorize these carbapenemase or beta-lactamase into two categories. One is called as serine beta-lactamase, second is metallo-beta-lactamase. So serine beta-lactamase are class A, C and D. So class A is very important, which include KPC, which is the most notorious carbapenemase produced by most of the Enterobacteriaceae. Along with class C we have AMP-C, not so important. Then class D, OXA48, which is very common in India. So in class B again we have NDM. So NDM, although being first isolated in India, that is why I call it New Delhi metallo-beta-lactamase. But now, as we are seeing in our data, so NDM is not that frequent as being publicized previously. It is not that common. So basically now whatever new cephalosporins we are using, basically there's a combination of beta-lactam and beta-lactamase inhibitor. So those beta-lactamase which we are combining, basically they have to act against all these. They have to block the activity of all these so that the beta-lactam antibiotic can be of effect. So this new antibiotic like meropenem, Veborbactam combination. So this is a new thing. So this will be soon coming up in India as well. So it is invasive infection caused. We all know that invasive infection caused by carbapenemase producing Enterobacteriaceae result in mortality which is as high as 26 to 44%. So with the help of Verobactam, this drug combination enter the outer membrane of bacterium like Klebsiella pneumoniae by various porins, and this basically inhibit the class A and class C beta-lactamase. So class A and C I have told you already. Class A include KPC and class C AMP-C, but doesn't inhibit the class B and D. So class B I already have told you is New Delhi metallo-beta-lactamase, and class D is OXA48. OXA48 is very common. So these two enzymes are not inhibited by this beta-lactamase inhibitor. So although it has shown a very good efficacy, now in fact, so it is being said that now this should be, so various studies have been done about this. Is now a proven thing, efficacy of drug in various randomized control, open-ended randomized controlled trials, prospective trials have been done in various studies. It has been proven it's effective. So in one of the study which I have quoted here, it's a randomized phase 3 study where meropenem, Verobactam was administered monotherapy to patient with confirmed or suspected CRE infection. So the efficacy was compared to the monotherapy or combination of various antibiotic like polymyxin B, colistin, carbapenem, aminoglycoside, ceftazidime, avibactam, and it was found to be much superior. and it has considerable reduction in the morbidity and mortality, and safety profile of this drug is much higher than the other polymyxins and other aminoglycoside. So this is now found to be an effective therapeutic option for treatment of hospital-acquired pneumonia and also ventilator-associated pneumonia, and it is now recommended to be used as a first-line treatment for treatment of infection from KPC-producing pathogen, so which are restricted to the particular infection. So it should be restricted for only these pathogen, unless otherwise the same thing which we are seeing now in case of ceftazidime avibactam. Initially in ILBS, 100% isolates were sensitive to this antibiotic, but now globally also resistance rate has been reported. But in our case, resistance to ceftazidime avibactam has been alarming, because now it is not being used as a reserve antibiotic. Now in our case, we are using as a first line of management, whether in the ICU or the ward. It has become the first line of management, although it has been proposed as a carbapenem sparing drug, and should be used very, very judicially once we have our sensitivity profile in hand. So new antibiotic like plazomicin is also being used. It is also approved by FDA in 2018. This is normally used in a combination with other. So initially it was approved for complicated UTI infection and also pyelonephritis. So basically the important point of most of the aminoglycoside, basically they are inhibited by the aminoglycoside modifying enzyme, which are produced by the organism. Now this agent is particularly resistant to the aminoglycoside modifying enzyme, so its efficacy is maintained for long, and it's also MIC 50 is quite low as compared to other aminoglycoside. You can see for plazomicin it is only 0.5, for gentamicin, for amikacin it is quite high. So it will be effective in lower dose, so that is why the resistance will be slower, and obviously there is also no cross resistance. So various studies have been again published, again data is there. So initially it was not named, so at that time when I quoted this study that was not named, it was called as ACHN 490 molecules. So at that time when it was compared, it was found to be more effective than any of the other aminoglycoside, less of the toxicity.
What about any data on the liver patients?
Sir, there is no study actually available. I have tried to find out, especially liver-centric patients. So I couldn't find anything which is related to the liver in liver patients.
And the renal safety, till what EGFR you can use plazomicin?
The plazomicin is still not available here, so they have not recommended that it is a contraindication. In fact, it is a drug of choice for complicated UTI and even pyelonephritis. Safety profile is quite high as compared to aminoglycoside. That is why it is being proposed to be used in comparison to other aminoglycoside. So various trials have been done. EPIC trial and CARE trial has been done. Now it is said that it is also being tried apart from now UTI, complicated UTI and pyelonephritis. It is also being now tried for other conditions like ventilator-associated pneumonia as well as hospital-associated pneumonia. It is being tried for these conditions. Phase 2 trials are already on. So now there is a new anti concept called as, cifediracol is a new thing. So this is a siderophore cephalosporin. Now these siderophore cephalosporins use a novel concept that, that most of the microbes, they require RN for their metabolism. So these kind of antibiotic, what they do, they use these same channels which are used by the organism to take iron inside. So they chelate the iron and they move inside the organism with the help of these channels. So the chances of resistance is quite high. And this cephalosporin, like other cephalosporin, the mechanism of action is inhibition of penicillin binding protein, which is in the periplasmic space. So this antibiotic is very novelly taken by the siderophore into the periplasmic space, and then it selectively inhibit the cell wall synthesis by inhibiting the penicillin binding protein. So therefore chances of resistance are actually negligible. There is no efflux pump which can be activated, there are no porin channel which can be activated, there is no enzyme deactivation, there is no target modification. So none of these things are possible. So this is what is being done, and but because of this it is now at the widest spectrum of antibiotic. So it is the only cephalosporin now till date which is effective against Acinetobacter baumannii. Otherwise we know that Acinetobacter baumannii cephalosporins have no role. So this is actually resembling 4th generation cephalosporin, but because of its siderophore potential, it is becoming a very, very effective. So it is also now effective against Pseudomonas and Acinetobacter, which are two notorious pathogens. So which we know that both these pathogens, Pseudomonas and Acinetobacter, so they became resistant to the antimicrobial agent not only by producing enzyme, but more commonly because of porin expression and increased efflux channel. So because this agent can escape both the porin channel and efflux channels, so that is why it is becoming the first line of choice. It will become a first line of choice for, in fact, all the nosocomial gram-negative infection in future. So it was, as you can see that in 2020 indication for treatment of
hospital-acquired bacterial pneumonia and methylated bacterial pneumonia caused by following bacteria, Bomani, E. coli, Enterobacter, Klebsiella, Pseudomonas, Serratia were also added. So now it is also approved indication by FDA. So in fact, it is the first cephalosporin now which is used for treatment of Acinetobacter baumannii. So now, obviously, we have discussed that this is a thing, the modification in the molecule make it more effective. Several studies have been published. Now it is a proven drug. So, so the relative novelty of ability of overcome all three mechanisms of resistance, as I have discussed, the production of bacterial beta-lactam escape. It also escaped the efflux pump. It also escaped the porine channel. So, as I have discussed with you, as I have already told that they use the same mechanism like a Trojan horse mechanism. They move inside the cell with the help of the same channel through which the RN thing is taken up by the organism. So major point in favor of this antibiotic is the stability against wide range of serine and metallobacter. Now serine beta-lactam, as already I have told you, include class A, C and D, and also metallo is class B. That means it is covering all kind of now beta-lactamases are being covered, such as KPC, Oxa, NDM. All are being covered now. A, C, D, all are being covered. So now this is a future. Now these are the few now drugs which are in the pipeline. I am not focusing much because not many of them are of use to us, because most of them are for either MRSA, VRE or ESBL. We are going beyond all these things. So we are talking about now CRE as all. So now this is the guideline which I have taken it from ICMR, given in 2022. Guidelines are given by ICR. So guideline on diagnostic and management of carbapenem resistance gram-negative infection. So this obviously I am not going to diagnostic modality, which is for lab people. So I am going to the management part. So this is what they are saying, that carbapenem resistant GNB infection can be broadly categorized as those which are for Enterobacteriaceae, predominantly E. coli, Klebsiella. Those resistance which is because of the Acinetobacter baumannii, and third is those resistance which is for Pseudomonas aeruginosa. Now, as I have told you that for Enterobacteriaceae, the most common mechanism of resistance is production of carbapenem enzyme, which can be either class B, which can be class D or class A. So, which can be metallobeta-lactamase, OXA48 or KPC. So, this is the outline. Now, what the ICMR says now. So, in case of carbapenem resistance Enterobacteriaceae, what it is recommended that in the BioFire report, you already, in the multiplex PCR, you already get the genes which are being expressed. You know what we are reporting. So if it is organism is only NDM producing, then first choice is prolonged infusion of ceftazidime, avibactam and aztreonam, which is done over the 3R. This is the first choice which should be used. Obviously, if it is sensitive, obviously along with the sensitivity, if the gene is being expressed and is sensitive to avibactam, then this has to be the first choice. So other options which are there include polymyxin. And obviously, polymyxin in this case, poly B cannot be used for UTI because of its toxicity. So we have to combine this with other agent which is being susceptible, which can include TG-cycline, aminoglycoside or even IV phosphomycin. Or we can also try high dose carbapenem if the MIC is less than 16. If the MIC, so these are the other options. So TG-cycline, as we all know, can be used majorly for intra-abdominal and skin and soft tissue infection. TG-cycline has no role in bloodstream infection or pneumonia as a standalone agent. And aminoglycoside are used for uncomplicated infection like UTI and where the source reduction has been done. So this is a protocol ICMR has given. Now same protocol they have given for production of NDM along with NDM along with OXA48. So if the OXA48 is also being produced, same thing has to be used. We have to use prolonged separate aztreonam, because aztreonam will be taking care of NDM and OXA48 will be taken care by ceftazidime avibactam. Same protocol is being followed for this group also. Again, first line is this, second line again polymyxin B or carbapenem with MIC having less than 16 can be used in combination high dose. TG-cycline aminoglycoside can be used. Then in case of OXA48, we know that we don't have to take care of NDM. So there is no point in adding aztreonam in that case. If it is a OXA48 producing Enterobacteriaceae, so in that case the ICMR recommend the use of only ceftazidime avibactam, which has to be in a prolonged infusion, which has to be ideally within 3R, unlike half an hour, which is done at most of the places. So, and lastly, if it is KPC producing, so in KPC producing also we don't have to take care of that NDM. So in that case we have to use only ceftazidime avibactam combination has to be used. So that means in most of the cases it is saying that we have to restrict ourselves to Cefta IV and we should now for the some time actually we should have to make a policy that we have to withhold use of carbapenem. In all the areas of ILBS, I recommend first on the hepatology side and surgical side, we should restrict use of carbapenem for some time and see how it works. Because if you are using both of them, because I have seen patients started on different antibiotic in ICU, then patient go to SDU, some de-escalation is being done in ward, and everything is changed suddenly. So this approach kind of thing will not help us in controlling the antimicrobial resistance. So once it is started, it has to be done in given a proper dose, and proper duration is very, very important. De-escalation also, so which Dr. Harsh will be discussing, is also very important. So this is what the ACMR is saying. It is not naming any fancy antibiotic. What all I have discussed, all fancy things which are not yet there. The ground reality is that we have to play with all these antibiotic alone. Now other problem is crab. So crab is carbapenem resistance Acinetobacter baumannii. So in this case we have one weapon called as, we all know, the sulbactam. So sulbactam alone has no antibacterial activity for most of the pathogen, but we know that sulbactam itself has a antibacterial activity against Acinetobacter baumannii especially. So we can use treatment options for A. baumannii include high dose sulbactam which can be given alone, or if ampicillbactam is sensitive, it can be given, or we can give ceforazone sulbactam, this can be given. So along with other drugs like minocycline, tigecycline can also be used in case of Acinetobacter baumannii resistance. Now again they have divided into mild, moderate and severe. It's very difficult to say mild, moderate. Mild means hemodynamically stable patient. So sulbactam is given alone. If mild infection with A. baumannii, hemodynamically stable patient, non-ICU patient, not on ventilator, we can start with sulbactam alone in high doses. So even if resistant sulbactam, still it is effective option. In moderate to severe infection, we have to combine at least 2 agents, and out of these 2 agents, 1 agent has to be sulbactam. And in case of respiratory Acinetobacter baumannii, so there is no role of nebulized antibiotic. ICMR says there is no role of nebulized antibiotic in case of treating respiratory Acinetobacter baumannii. And obviously, A. baumannii infection in the respiratory tract has to be taken with a pinch of salt, because we know that this pathogen is a normal colonizer of the upper airway. So we have to be very, very sure that the count which we are giving is very, very important, because it is more commonly a colonizer. In fact, we also make a comment below, if the count is less, we make a comment that probable colonizer. So this is A. baumannii should not be chased in all the cases in case of respiratory infection unless proven. So this is what has to be done, and this is what I have to say. So in our case, it is not the problem is basically we have to stop the overuse of antibiotic, not about the antibiotic, it is about the overuse, and we can say probably abuse of the antibiotic. So thank you so much.